This is Dr. Lyle Jones, Editor-in-Chief of Continuum. Thank you for listening to Continuum Audio. Be sure to visit the links in the episode notes for information about earning CME, subscribing to the journal, and exclusive access to interviews not featured on the podcast.
Hi all, this is Dr. Casey Albin. Today I'm interviewing Dr. Jessica Frey about her article, Tourette Syndrome and Tic Disorders, which appears in the August 2025 Continuum issue on movement disorders. Dr. Frey, thank you so much for being here and welcome to the podcast. I'd love for you to briefly introduce yourself to our audience.
Thank you for having me here today. My name is Jessica Frey, and I am a movement disorder specialist at West Virginia University. I'm also the Movement Disorder Fellowship Director, as well as the Neurology Clerkship Student Director.
Dr. Frey, I feel like this was one of the things I actually had no exposure to as a resident. For trainees that kind of want to get a better understanding of how these are managed, what kind of counseling you do, what kind of interventions you're using, how can they get a little bit more exposure?
That's a great question, and I actually had a similar experience to you. I did not see that many patients with Tourette syndrome while I was in my residency training. I got a lot more exposure during my fellowship training, and that's when I actually fell in love with that patient population, caring for them, seeing them be successful. I think it depends on the program that you're in. During the pediatric neurology rotation might be your best bet to getting exposure to patients with Tourette syndrome, since a lot of them are going to be diagnosed when they're quite young. And sometimes they'll even continue to follow through young adulthood in the pediatric neurology clinic. However, up to 20% of patients with Tourette syndrome will have persistent tics during adulthood. And so I think it is important for neurology trainees to understand how to manage them, understand what resources are out there. So if you have an interest in that, absolutely try to follow either in the pediatric neurology department, or if you have a movement disorder program that has a Tourette clinic or has a movement disorder specialist who has an interest in Tourette syndrome, definitely try to hang out with them, get to know that patient population, and educate yourself as much as you're able to educate the patients as well.
Yeah, I think that's a fantastic advice. You wrote a fantastic article and it covers a lot of ground. And I think let's start at some of the basics. When I think of Tourette syndrome and tics, I think of Tourette syndrome having tics, but maybe not all patients who have tics have Tourette syndrome. And so I was wondering, A, if you could confirm that's true. And then could you tell us a little bit about some of the diagnostic criteria for each of these conditions?
Sure. So a tic is a phenomenological description. So basically what you're seeing is a description of a motor or phonic tic, which is a particular type of movement disorder. Tourette syndrome is a very specific diagnosis, and the diagnostic criteria for Tourette syndrome at this point in time is that you need to have had at least one phonic tic and 2 or more motor tics over the course of at least a year before the age of 18.
Got it. So there's certainly more specific and a lot more criteria for having Tourette syndrome. I was struck in reading your article how many myths there are surrounding Tourette syndrome and tic disorders kind of in general. What's known about the pathophysiology of Tourette syndrome and what are some common misconceptions about patients who have this disorder?
Yeah, so I think that's a really excellent question because for so many years, Tourette syndrome and tic disorders in general were thought to be psychogenic in origin, even dating back to when they were first described. The history of Tourette syndrome is quite interesting in that when Tourette, who was named after, was working with Charcot, a lot of the initial descriptors were of actual case reports of patients who had more psychogenic descriptions. And eventually they became known as tic disorders as well. It wasn't until the discovery of Haldol and using Haldol as a treatment for tic disorders that people started to change their perception and say, okay, maybe there is actually a neurologic basis for Tourette syndrome. So In terms of the pathophysiology, it's not completely known, but what we do know about it, we think that there is some sort of hyperactivity in the corticostriatal thalamocortical circuits. And we think that because of this hyperactivity, it leads to the hyperactive movement disorder. We think similar circuitry is involved in conditions like OCD or obsessive compulsive disorder, as well as ADHD or attention deficit hyperactivity disorder. And because of that, we actually do tend to see an overlap between all three of these conditions in both individuals and families.
And hearing all of that, does this all come back to sort of dopamine and sort of behavioral motivation, or is it different than that?
It's probably more complex than just dopamine, but there is the thought that dopamine does play a role. And even one of the hypotheses regarding the pathophysiology is actually that these tics might start as habits. And then when the habits become more common, they actually reshape the dopaminergic pathways. And each time a tic occurs, there's a little bit of a dopaminergic reward. And so over time, that reshapes those hyperactive pathways and changes the actual circuitry of the brain, leading it to be not just a habit, but part of their neurologic makeup.
It's fascinating to hear how that actually might play into our neural circuitry and over time rewire our brain. Fascinating. I mean, this is just so interesting how movement disorders play into such behavioral regulation and some comorbid conditions like ADHD and OCD. I thought it would be really helpful, maybe to our listeners, to kind of think through a case that I suspect is becoming more common. So, if it's okay with you, I'll present sort of a hypothetical.
Absolutely.
This is a father bringing in his 17-year-old daughter. She's coming into the clinic because she's been demonstrating over the past 4 to 6 weeks some jerking movement in her right arm. And it's happened multiple times a day. And it was a pretty sudden onset. She had not had any movement like this before. And then several weeks ago, started moving the right hand. And then it became even more disruptive. Her right leg was involved. She had some squunching of her face. This is all happening at a time where she was dealing with some stress, maybe a little bit of applications around college that she was having a lot of anxiety about. How would you sort of approach this case if this is someone who comes to your office?
Sure. So I think the first thing that you want to get is a good solid history, trying to understand what is the origin of these abnormal movements and what led to the abnormal movements. Now, a key thing here is that in Tourette syndrome and most physiologic tic syndromes, there's a pretty early onset. So in Tourette syndrome, the expected age of onset is between the ages of 5 and 7 years old. So to have kind of acute new abnormal movements as a 17-year-old would be very unusual for a new onset diagnosis of Tourette syndrome. However, there's a couple of things from the history that could help you. One would be, were there ever tics in the past? Because sometimes when you think retrospectively, a lot of these patients might have had simple eye blinking tic or a coughing tic when they were a child, and perhaps they did have Tourette syndrome, a very mild case of it, but because the tics were never that pronounced, they never went to see anyone about it, and it was never known that they had Tourette syndrome in the first place. If there is no history like that and the movements are completely new, out of the blue, of course you want to rule out anything acute that could be going on that could be causing that. Looking at the phenomenology of the movements can also be very helpful. When you're looking at abnormal tic movements, you would expect most cases of something like Tourette syndrome to occur first in the midline and go in a rostrocaudal distribution. So you mostly see things happening with eye blinking, throat clearing, sniffling, neck snapping. These are some of the immediate tics that start to happen. We also usually start to see simple tics as opposed to complex tics at the beginning. Now, over the course of time, many patients do develop more complex tics that might involve the arms or the extremities, but that would be unusual to see this as a presenting feature of new onset Tourette syndrome.
Got it. So I'm hearing that the history really matters and that sometimes like those like first onset seizures, I imagine as a neurointensivist, we see a lot of patients who've had seizures who think that they're presenting the first time. And then we go back and we say, well, actually, they have had some abnormal movements at night. Sounds like it's very similar with these movement disorders where you have to really go back and ask, well, was there some sniffling? Did they go through a phase where they were grunting frequently? Because I can imagine that many children make those behaviors and that it may not have registered as something that was cause for concern.
Absolutely.
And then the other thing I heard from you was that the phenomenology really matters and that there is a typical presentation starting from sort of the face and working the way down. And that can be really helpful. But in this case, the family is quite clear no. She's never had movements like this before. This is nothing like this. We promised you did not go through a phase where she was coughing or blinking, or this is all totally new. And the phenomenology, they say, no, she did not start with blinking. It definitely started in the arm and then progressed in its complex movements. So knowing that about her, how does that sort of shape how you move forward with the diagnosis?
Yeah, so really good question. And this is something that I think really peaked during the COVID-19 pandemic. We saw an influx of patients, especially teenage girls or young adult girls, who basically would come in and have these new acute onset abnormal movements. We weren't sure what to call them initially. There was some discussion of calling them explosive tic disorder and things like that. A lot of these actually looked very similar to psychogenic non-epileptic seizures, where they would come into the emergency department and have many abnormal movements that were so severe that they were having a tic attack and couldn't stop the abnormal movements from occurring. And we saw so many of these cases during the COVID-19 pandemic that it eventually became known as a distinctive diagnostic criteria with the name of functional tic-like behavior, or FTLB. When we think about functional tic-like behavior, we think that these tics are driven more by anxiety and stress. A lot of times the backstory of these patients, they were in a very stressful situation, and that's when the abnormal movement started. So a very similar kind of backstory to patients that might develop psychogenic non-epileptic seizures. These tics were popularized, for lack of a better term, via social media during the COVID-19 pandemic. One article is out there that even has called these functional tic-like behaviors as a pandemic within a pandemic, because there was such a strong showing of tic-like behavior in the clinics during the COVID-19 pandemic. Although social media was thought to play a big role in these functional tic-like behaviors, we think that there's probably a little bit more complexity and nuance to why these functional tic-like behaviors develop. There is probably a little bit of a genetic predisposition. There's probably some other psychosocial factors at play. And when we see cases like this, the best thing that you can do is educate your patients about the differences between functional tic-like behaviors and tics that we see associated with conditions like Tourette syndrome. And then the best types of treatments that we have seen thus far are treating any underlying stressors, if any of those exist, as well as cognitive behavioral therapy has been shown to be somewhat helpful. As the COVID-19 pandemic has wound down, we have actually seen a lot less cases in our clinic. And one reason we think is less stressors, less uncertainty for the future, which we think was a driving precipitant of some of these cases. But it also is not as popularized in the media as well. There are a lot of TikTok users in particular, which lent itself to the name TikTok tic. These videos are not as viewed or not as popular as they were during the COVID-19 pandemic. One reason being that because we are not all relegated to our homes, constantly looking to online sources of information, just in general, we have kind of not been on the internet as much as we were during the COVID-19 pandemic. as a society as a whole.
This is really fascinating how the environmental milieu, for lack of a better word, like really influenced how patients were experiencing sort of functional neurologic disorders. In your article, you describe really these three baskets of primary tic, which can then be a part of Tourette syndrome, functional tic like behaviors, which really were a unique manifestation of stress and anxiety, specifically during the COVID-19 pandemic, and then tics as a manifestation of some either different underlying etiology or medication side effect. So, when do you get concerned about that secondary etiology?
So, secondary tics can occur in a variety of instances. I think some of the more common examples would be genetic disorders. So, Huntington's disease is a really good example. I think we all associate chorea with Huntington's disease. That's probably the most commonly associated phenomenology that we see with Huntington's disease, but we can see a variety of movement disorders in Huntington's, and one of them is tics. So when we see tics in association with other types of movement disorders, we should be thinking about a possible genetic etiology. If we see tics in association with other neurologic symptoms, such as seizures or cognitive changes, we should be thinking that this is something besides a primary tic disorder. You also mentioned medication use, and it's really important to think about tardive tics. I know we often think about tardive dyskinesia, and the first kind of phenomenology that jumps into our brain is usually chorea, because it's those abnormal lip movements, finger movements, toe movements that we see after a patient has been on, for example, an antipsychotic or an antiemetic that has antidopaminergic properties. However, we can see a variety of abnormal movement disorders that occur secondary to antidopaminergic medications, especially after abrupt withdrawal of these antidopaminergic medications. And tics are one of them. There have been cases reported where people that have tardive tics will still report that they have a premonitory urge as well as a sense of relief after their tics. So it actually can seem very similar to Tourette syndrome and the tics that people with Tourette syndrome experience on a regular basis. The key here is that the treatment might differ, because if it's due to an antidopaminergic medication or abrupt withdrawal of that antidopaminergic medication, you might need to treat it a little bit differently than you would otherwise.
I love that you bring in, it's not just looking at their specific movement disorder that they may be coming to clinic with, that tic disorder, but are there other movement disorders? Has there been a change in their medication history? Have they had cognitive changes? So, really emphasizing the importance of that complete and comprehensive neurologic history, neurologic physical exam to really get the complete picture so that it's not honing in on, oh, this is a primary tic. That's all there is to it, because it could be so much more. I know we're getting close to sort of the end of our time together, but I really wanted to switch to end on talking about treatment. And your article does such a beautiful job of talking about behavioral interventions and really exciting new medical interventions. But I would like to, if you don't mind, have you focus on what behavioral counseling and what education do you provide for patients and their families? Because I imagine that the neurologist plays a really important role in educating the patient and their family about these disorders.
Absolutely. When we think about treatment, one of the most important things you can do for patients with Tourette syndrome or other primary tic disorders is educate them. This remains true whether it's a primary tic disorder that we see in Tourette syndrome or the functional tic-like behavior that we've discussed here. A lot of times, because there is such a stigma against people with tic disorders and Tourette syndrome, when they hear that they have Tourette syndrome or they are diagnosed with that, sometimes that can be an upsetting diagnosis. And sometimes you have to take time explaining what exactly that means and debunking a lot of the myths that go along with the stigmas associated with Tourette syndrome. I think a lot of times people are under the false assumption that people with Tourette syndrome cannot lead normal lives and cannot hold down jobs and cannot be productive members of society. None of that is true. Most of my patients have great lives, good quality of life, and are able to go about their day-to-day life without any major issues. And one of the reasons for that is we do have a lot of great treatment options available. Another important stigma to break down is that people with tic disorders are doing this for attention or doing this because they are trying to get something from someone else. That is absolutely false. We do think that the tics themselves are semi-volitional because people with Tourette syndrome have some degree of control over their tics. They can suppress them for a period of time. But a lot of people with tic disorders and Tourette syndrome will describe their tics as if you're trying to hold onto a sneeze. And you can imagine how uncomfortable it is to hold in a sneeze. We're all able to do it for a period of time, but it's much easier to just allow that sneeze to occur. And a lot of times that's what they are experiencing too. So although there is some degree of control, it's not complete control, and they're certainly not doing these tics on purpose or for attention. So that's another important myth to debunk when you're counseling patients and their families. I think the dynamic between young patients that are presenting with their parents or guardians, sometimes that dynamic is a little bit challenging because another faulty assumption is that parents feel they are responsible for having this happen to their child. There used to be a really strong sense that parents were responsible for the tics that occurred in their children. And that is also absolutely not true. Parenting has nothing to do with having the tics or not. We know that this is a neurodevelopmental disorder. The brain is indeed wired differently. And it's important to counsel that with the parents too, so that they understand what tools they need to be successful for their children as well.
I love that. So it's a lot of partnership with patients and their families. I really like that. This is just a wire different. And I hope over time that working together, we as neurologists can help break down some of that stigmatization for these patients. This has been an absolutely phenomenal discussion. I have so enjoyed learning from your article. For the listeners out there, there are some really phenomenal tables that go into sort of how to approach this from the office perspective, how to approach it from the treatment perspective. So thank you again, Dr. Jessica Frey, for your article on Tourette syndrome and tic disorders, which appears in the August 2025 Continuum issue on movement disorders. Be sure to check out Continuum audio episodes from this and other issues. And thank you so much to our listeners for joining us today.
Thank you for having me.
This is Dr. Tishme Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continpub.com/audiocme. Thank you for listening to Continuum Audio.